So we are switching gears and we are talking about when to defer a total knee arthroplasty. And we will try and define the yellow and red flags. Now we toil every day to secure an excellent outcome. In order to achieve this goal, we need to be able to preempt patients that have non-modifiable risk factors from those who have modifiable risk factors and where preoperative optimization can avoid morbidity and mortality. So now for the last few years, there has been a paradigm shift in the preoperative patient optimization. So surgeons are seeking optimization preoperatively versus just obtaining a clearance. Now, clearance by an internist, a cardiologist, and an anesthetist is not sufficient, and you'll see why. Clearance is not based on any scientific thresholds or evidence-based criteria. It fails to identify and rectify risk factors for adverse outcomes. So, whereas preoperative patient optimization requires us to understand that this procedure is an elective procedure, there is ample opportunity to optimize modifiable risk factors preoperatively at least 4 to 6 weeks ahead of time, use evidence-based criteria, and thereby reduce mortality and morbidity, maximizing long-term outcomes. So Brzezinski et al. Found that almost 85% of arthroplasty patients have at least one modifiable risk factor. And I'm going to show you a list of these modifiable risk factors, and we will choose to call them yellow flags. As you will notice, obesity, malnutrition, diabetes, anemia, smoking, opioid use, they constitute almost a quarter to half of the arthroplasty population. The additional yellow flags are cardiovascular associated problems, chronic lung, chronic kidney, chronic liver disease, symptomatic UTI, symptomatic dental disease, and these we will choose to call as the modifiable risk factors. Now, in contradistinction to these, we have the non-modifiable risk factors, which include advanced age, neurodegenerative disorders, such as severe depression, schizophrenia, Parkinson's disease, etc., ipsilateral advanced hip and ankle disease, peripheral vascular disease with intermittent claudication, which will also mimic leg pain, chronic venous stasis and associated with recurrent cellulitis, severe lymphedema. Additionally, osteomyelitis in the vicinity of the knee joint, spinal stenosis and cervical and lumbar myelopathy, which is associated with stenosis, which leads to weakness in the limb. This could be primary or iatrogenic in people who have already had some spinal procedure. And then psoriasis and fungal infections on the same extremity, and neuropathic arthropathy. Now, these are non-modifiable risk factors. So we'll just quickly move on. Now, the poorly optimized yellow flags are associated with adverse outcomes. And what are these adverse outcomes? These are increased rates of in-hospital complications, which include pulmonary emboli, myocardial infarction, and need for transfusions. Joint infections, which carry a 5-year mortality rate of 22%, are significant. Increased readmissions, length of stays, increased costs, revisions, and deaths. So the objective of the next few minutes will be to provide recommendations to screen and address these yellow flags, talk about evidence-based criteria prior to surgery for risk factor optimization, and at the same time identify red flags and defer the procedure altogether. So obesity, as we see, is fairly common in most populations around the globe, whether it's the United States of America or us. Morbidly obese patients have a 2 to 6-fold increased risk of readmissions, reoperations, superficial and deep infections, wound dehiscence, urinary tract infections, reintubations, renal insufficiency, in-hospital mortality, and higher total hospital costs. We all know it. it is always associated with additional systemic problems, heart, kidney, strokes, sleep apnea, etc. So what are the recommendations? Is to identify and optimize concomitant morbidities, take care of them, which includes malnutrition, diabetes. Ahmed will talk about it in detail. Delay surgery for BMIs more than 40 kilogram per meter square until the BMI is reduced below this threshold. Next comes malnutrition. The incidence is fairly high, from 4 to almost 50% of arthroplasty population. Hypoalbuminemia is an independent risk factor for all kinds of morbidities that you can think of. Parkinson's disease, dementia, and cancers are associated with abnormal transferrin and abnormal total lymphocyte counts. There is a high prevalence of malnutrition among obese arthroplasty patients, and this comes as a surprise. These obese patients can be malnourished. And the NESCIP database also finds that hypoalbuminemia is a stronger predictor of complications, readmissions, reoperations than obesity alone. So the recommendations are to obtain preoperative serum albumin, transferrin, and total lymphocyte counts in patients with particular comorbidities. And for albumin levels less than 3.5, transferrin less than 200 milligram per deciliter, and total lymphocyte counts less than 1500, the surgery should be delayed and patient referred for nutritional counseling. Diabetes, more will be said by Ahmed, but the prevalence is fairly high, almost more than a quarter of arthroplasty patients. Preoperative diagnosis of diabetes more than doubles the independent risk of prosthetic joint infection. Uncontrolled diabetes has increased odds of stroke, UTI, ileus, hemorrhage, wound infection, and death. Similarly, type 1 diabetes is associated with greater joint infection rates than type 2 diabetes. So the recommendations are to screen patients preoperatively with A1C and delay surgery until the A1C is at least less than 7.5. Anemia for arthroplasty surgeons is defined as hemoglobin of less than 12 gram per deciliter in females and 13 gram per deciliter in males. So preoperative anemia is reported to be present in almost a quarter of patients, associated with increased transfusion rates, reoperations, joint infections, cardiac, renal, pulmonary complications, sepsis, etc. So blood transfusions are also noted to be required mostly by in arthroplasty patients, in patients with a hemoglobin of less than 13. The recommendations are to obtain hemoglobin level at least 4 weeks pre-op and work up and treat the newly diagnosed or chronic anemia, and surgery should be delayed until the hemoglobin levels rise above 12 gram in women and 13 gram in men. A good number of people are smokers, and therefore, like the previous speaker emphasized, history is important. Current and former smokers had increased risk of PJI compared to the non-smokers. Current smokers had a greater risk than former smokers. Hence, we should ensure that smoking is abandoned at least 4 weeks pre-op. A large majority of people are taking opioids for pain relief, and we know that preoperative opioid use is associated with inferior post-operative patient-reported outcomes, increased opioid use after surgery, and increased risk of complications. So recommendations are to use multimodal pain management, avoiding opioids, and wean off opioids at least by 50% 4 weeks prior to surgery. Cardiac complications represent a large majority of people that suffer from morbidity and mortality from this condition alone. Rates can be as high as 2 to 8 in 1,000. Recommendations are to seek preoperative optimization, preferably with a cardiology consult and a preoperative stress test, especially in people with advanced age, male gender, family history of cardiovascular disease, associated comorbidities such as diabetes, hypertension, dyslipidemia, smoking, and obesity again surfaces here. And people with a reduced EF must have a cardiac consultation and risk stratification. It is mandatory with a history of ischemic heart disease, stroke, and arrhythmia. COPD is also independently associated with morbidity, and therefore it must be optimized in consultation with a pulmonologist. Chronic kidney disease is prevalent, and the numbers are rising. It is associated with poor nutritional status, anemia, diabetes, hypertension, poor immunity, CKD patients carry a higher risk of transfusion and readmission. It is an independent risk factor for mortality in the first 90 days. So what are the recommendations? End-stage CKD may require dialysis, kidney transplant, which only increases the risk of complications. And therefore, the benefit versus risk has to be discussed preoperatively with the family and the patient himself. So what about cirrhosis? Rates of complications are significantly high in patients with cirrhosis. Arthroplasty should not be offered in patients with a history of hepatic decompensation, variceal bleed, who are more than 70 years, have a low platelet count, and where the cirrhosis is Hep B related. Joint infections, superficial and deep, systemic infections are the most common cause of morbidity and mortality. So what are the recommendations? TKA should be performed with extreme caution, even with child class A, which sometimes we fall into the pit, and not to be offered with child class B and C cirrhosis altogether. And the risk benefit should be discussed with the patient, even with the child class A. Symptomatic UTI is a risk factor for joint infection and therefore must be treated before this elective operation. Asymptomatic bacteriuria is not a problem and therefore does not need pursual. What about prostatism? Symptomatic BPH is a risk factor for joint infection, and older men with prostate disease should complete required treatment before being offered joint replacement, and not afterwards or at the same time. I've heard sometimes 2 procedures are done at the same time. Symptomatic dental disease is a risk factor for joint infection and should be treated before the arthroplasty. There is not enough evidence to support universal dental clearance. Oftentimes we come across neurodegenerative disorders, the classic example of which is Parkinson's. People can live up to 10 years after the disease is diagnosed. After TKA, functional ability does not improve. And functional ability means ability to walk without support. And in fact, functional ability is lost with the last stages of Parkinson's disease. So recommendations indicated only for disabling pain. Depression and anxiety, again, should be screened preoperatively because they have a higher association with morbidity. Unrealistic expectations are also yellow flags. On the upper right is what you think is the expectation, and the lower right is what the patient believes will be the case. So coming to the red flags, which are non-modifiable and where TKA should be deferred altogether, and these are long-standing varicose veins with leg ulcers, chronic lymphedema, psoriasis, peripheral vascular disease, ipsilateral advanced hip arthrosis or spinal stenosis associated with neurogenic claudication on the same side. So coming down to the last few 2 slides, summary is that yellow flags, which represent systemic diseases which compromise patients' ability to withstand anesthesia and metabolic demands of surgery and wound healing, should be addressed preoperatively on evidence-based criteria to reduce morbidity and mortality. And the red flags, which are non-modifiable risk factors, are not likely to improve mobility and jeopardize life and limb, and therefore surgery should be deferred. And thank you.